All right. Can you believe this is week 5 already? And just to remind you, this course is only 8 weeks long. This course is done with on March 2nd. And I'm thinking maybe next week we will do the application for the exam so you can give it a little time to process. And then, research shows that the sooner you take the exam after your coursework, the better opportunity you have for passing. And of course, we want to make sure that you're ready. Don't worry about being nervous because you're always going to be nervous. That is never going to go away. Never going to go away. But all right, so we're going to talk a little more about that next week. And this week, thanks to Jennifer, we have a case study from the quiz, and we're going to review it and see how in heaven's name did we come up with those codes. There were 3 diagnosis codes and 1 procedure code. ICD-10 PCS, of course. Okay, so let's get started. It's long. This case study actually covers 5 slides. So I'm going to read it, we're going to discuss it, and then we'll move on to the next part, okay? And you'll notice that this case study starts out with the procedure statement, okay? Bilateral decompressive cervical laminectomy, C4, C5, C6. Okay, so that's important that we know that. You'll notice that there is no diagnostic statement. And in most cases, when you are on the job, you will have a diagnostic statement at the top. But the reason why we're presenting these to you is we're trying to help you build a good habit. And I know from my own personal experience how easy it is to look at the diagnostic statement and the procedural statement at the top of the page, look at 3 pages of single-spaced operative notes and go, oh, I'm sure it's fine from the top, and just code from the top. But you cannot do that. You cannot do that because you need to know more about the procedure and how it was done. There are times when you will find little extra things in there that have to be separately coded that are only mentioned within the operative report, but not in the top headline. So this is a very important, if you are going to work in a hospital or even a same-day surgical center, it's very important that you get in the habit of reading the notes in their entirety. Okay, so after satisfactory general anesthesia, the patient was fixed in the Mayfield headrest, then turned prone over the Wilson frame and prepared for surgery. The skin over the suboccipital neck and upper shoulders were shaven, scrubbed with betadine scrub, painted with betadine paint, and draped for a sterile procedure. A midline 8-centimeter incision was made over the posterior spinous process of C3, C4, C5, and C6. Okay, so what you're going to get out of this in general teacher terms now, okay, is first of all, the patient had general anesthesia. Okay, second of all, not for ICD-10 PCS, however, for CPT coding, you need to know that this was a posterior incision over the back. And you're told this when the patient was turned prone. Remember, supine is nose up, prone is face down. So this tells you, and also, of course, the last sentence, which has the word posterior spinous process, tells you that this is a posterior surgical procedure. Now, what you do now, okay, I think it's on the next one. All right, any questions about this? Okie dokie. All right, dissection was carried down the deep cervical fascia, bleeding encountered, controlled with bipolar forceps. Bleeding was encountered and coagulated with bipolar cautery. The deep cervical fascia was incised on either side of the posterior spines of C4, C5, C6, and the paraspinous muscles were dissected away from the spine and lamina, retracted laterally to the side. A metallic clip was placed in the posterior spine of C4, and the lateral x-rays taken confirmed the exact anatomical location of the lesions at C3, C4, and C5. Okay, so what we need to know for the procedure codes, both CPT and of course ICD-10 PCS, this was an open approach. This is very clearly stated. Dissection was carried down the deep cervical fascia. Okay, and we also now have our diagnosis. Can you tell me what the diagnosis is? Why is this procedure being performed?
It's lesions at C3, C4, and C5.
Excellent. Very good. Exactly correct. Okay. So you see how that was buried all the way down here in this one little sentence. All right. Next. Rongeurs were used to remove the spine at C5 and the lamina at C5 out to the facet joints. Attention was then directed to the C6 lamina and the spine. The spine was removed and the lamina was removed out to the facet joints. And again, attention was then directed to C4 and the same performed. Once the laminectomy was complete, the ligamentum flavium was excised from the spinal dura. The dura remained intact. He did not have evidence of radiculopathy, therefore, foraminectomies were not done. Neural foramina was inspected and seemed to be patent. Okay, we good?
So far.
Pledgets of gel foam were then cut and placed over the exposed dura. The paraspinous muscles were allowed to fall back into place. Zero stay sutures were passed through the deep cervical fascia and muscle layer to be tied later. Deep cervical fascia was then approximated in the midline and interrupted 2.0 vicryl sutures. Then the subcutaneous fat was approximated with interrupted 2.0 and 3.0 vicryl sutures, and half-inch steri-strips were used for the skin closure. Sterile post-operative dressings applied. The patient was then turned supine, nose up. The Mayfield headrest was removed and the procedure was then terminated. The patient was awakened and transferred to the recovery room, having tolerated the procedure quite well. At this point, he is awake, talking, and moving all of his extremities, which are very, very important. Estimated blood loss for the entire procedure was 125 cc's. It was unnecessary to transfuse him. Sponge count, cottonoid count, instrument counts were all correct. Yay. Hi, Nikki. All right, then. So we have our diagnosis codes and our procedure code. So as Jennifer said earlier, we came back to, yes, the lesions at C3, C4, and C5 are our diagnosis codes, and you will find them to be S as in sugar, 14.112, which is complete lesion at C2 level of cervical spinal cord. S14, well, and they all need a seventh character of A for initial encounter. S14.113A, complete lesion at C3 level, and that's not right. This should be 13, 14, and 15. S114.113A, which is the C3 level. S14114A, complete lesion at the C4 level, and S14.115 at the C5 level. So that gives us our our three diagnosis codes. Okay. So now, because Nikki was late, she gets the honor of steering us in the direction of the procedure in ICD-10 PCS. And as we said before, bilateral decompressive cervical laminectomy, C4, C5, C6. Okay. Do you want me to walk you through it?
972-4209-80397.
Okay. Do you want me to walk you through it?
Because I had problems trying to make sure I found the right thing.
Understood. This is one of those cases where your understanding of medical terminology can actually throw you off, but it also reinforces the reason why you had to take anatomy and physiology. And I strongly suggest, if nobody has done this before, I strongly suggest that you
I can't hear you.
Yeah, I can't hear you either, Dr. Sapien.
can you hear me now?
Yeah.
Yeah.
You're not supposed to push this button.
You set your book on it, didn't you?
I did. You know how it is with these books. Okay. Now, I was just trying to find yeah, here it is. Okay.
Before we go to the procedure, can I make a statement?
You can say whatever you want.
Okay, no, I was just gonna tell you, I see where I went wrong with the lesion. Because see, I just went to spinal cord. And that is a completely different code because
well,
that gives you G95.9. Now I know I should have went to nerves.
G.
Yeah, that's what it says. Spinal cord, under lesion for spinal cord, it says G95.9. And that's why I was so lost. I should have went to nerve and then spinal.
Okay, well, then let me tell you something. This is what I was looking for. And it's relative. Okay.
Okay. I mean, if you want to do the procedure first, that's fine. I'm sorry. I just.
No. I have both books open here, so it's fine.
Oh, okay.
But this is what I wanted to show you, that in the front of your code books, you have these anatomic illustrations. And what that means is they will be with you during the exam. Now, I'm not sure that they would help you with something exactly of this nature, but
it didn't. It
didn't. Oh, so you okay? No. Well,
that took some of my time, because what I didn't when because when you look up certain things, it has so many different things like nerves and this and that, drainage. So I went looking in the front to make sure I had the right body part. And by me trying to make sure I had the right body part, it took time. So
yes,
I'm working
it does.
It takes time, and going back and forth trying to make sure you got the right code takes up time.
That's fun, isn't it?
No, not when I'm going over time.
Not when that clock is hammering at your head. I totally get it.
And I did not look at the clock. That's the thing. I was not watching the clock at all. I didn't realize the time had left me until the thing started flashing. And then time.
All right. And now we're going to do diagnosis to address what Jennifer said is very, very valid. Okay. When you look under lesion in the alphabetic index in your diagnosis coding book, okay, and you go to lesion and you go to spinal cord, let's see what it says. Oh, I see G95.9. Okay. Whereas, as Jennifer said, I'm going to write a book and it's going to be titled, As Jennifer Said.
I like it.
The questions Jennifer sent me every week.
Exactly. If you look under nerve spinal, it says C injury, comma, nerve, comma, spinal. Okay, so how would we get to that? Okay. When we, and this is important. Okay, so if I go to lesion and spinal cord and I see G95.9, so I'm going to turn to G95.9, A, B, C, D, E, F, G, H. And if you don't sing the alphabet song in your head, good for you. I do it every day, 10 times a day. Okay, so what I have here is G95.9, disease of spinal cord, unspecified, myelopathy, not otherwise specified. And that, there was nothing mentioned about myelopathy. And I'm just not feeling that that would be accurate, which is what Jennifer said. You got to this G95.9 and you said, yeah, not really. Okay. So we go back to the index, and this is when I take my finger and I just start at the top of the list and I run down all of the anatomical sites and consider anything that could be close. Okay. Now and here's another one we can take a look at is under lesion. If you stop at cervical nerve root, not elsewhere classified, G54.2. So I'm going to take a look at that and see what that gets me. And the reason why this is very helpful is sometimes the excludes notes will help you and point you in the right direction. So we have G54.9, nerve root and plexus disorder, unspecified. And what I see here in this whole category is actually nerve root disorders. There's nothing here about lesions, and I do not have anything that's going to help me find the lesions. So I'm going to keep looking down the list, at which point you would get to nerve and then spinal, and that's injury, nerve, spinal. And so now I'm going to go to that injury, INJ. I already hear you. You're saying, but look how long this is taking. And I understand that. Nerve injury, spine. And I'm going to look at spine.
That what took me so long. I got to the point where I just said, you know what? My time is up. I can't afford any more points ticking off.
Yeah,
And
that's
I
why I left.
understand,
Yeah.
I seriously understand your feeling about that. First of all, and if anybody knows different, please say something, but you will not have a case study that's this long and complex on the exam.
Oh.
No? Anybody?
I mean, it was like, I think it's like 2 of them that had a whole bunch that you had to actually go through.
You mean on your exam, or you mean on the?
No, I mean on the real certification exam.
There are questions that have lots of diagnoses on them.
No, I'm not diagnoses, but that are this long and intricate. Yeah. Okay. But look what happens. All right. Look what happens is.
But there wasn't anything this complex that.
That's what I meant.
That had to be looked in several different places.
That's what I meant. Okay, so thank you, because I was a little worried, because this would take me this long if it was me taking the test, and I already paid. You know, when you go to injury, nerve, spinal, right there is cervical, neck, S14, and that'll take you right to where you need to be. Okay, so sometimes, and I do believe, I can't swear to this because I'm not on the committee, but I do believe that when they create these questions and get these cases, that they look for things that are a little more direct, as opposed to this, which was, I had to have 3 false starts before I got to the right index listing. Okay. Does that sound reasonable for me to say?
Does. I had several false starts.
Yeah, I'm glad you went through, because having you go through the steps helped me realize, I know, because y'all have told us since day one, sometimes you have to keep looking. And I mean, and you know that, and you're looking through the book, and then you get confused, and then it's like, you will never find it.
It's a runaway train, Jennifer, a runaway train.
I have to tell you.
So to have you go through it helps.
That's good, because that's why we're here. Okay. But I have to tell you, and I swear to you, this is true, is throughout my career so far, and I've only been doing this for 20 years. And I say that meaning only 20 years. But the fact is that there are times, yes, that I want to throw my code book across the room. All right, maybe there were even a couple of times when I actually threw my code book across the room. But no, but the point I want to make is there are many times when I have had to say to myself, if a doctor can diagnose it, there is a code for it. And if a doctor can do it, there is a code for it. So the disconnect is in me and my ability to interpret what the doctor wrote. And that's why we get paid the big bucks. Oh, wait, we don't get paid big bucks. But that's why not everybody can do this job, honestly, because it does take that higher level of critical thinking. Ms. Johnson and I had a meeting just earlier today with some people with McGraw-Hill, and we were talking about this exact thing as we're putting together something for instructors across the country that teach coding. And we were talking about this exact thing is some people, outsiders, look at coding and they say, well, it should be very matter of fact. You know, you look at a word, you look it up in the book, it's like looking up a phone number in a phone book, if y'all know what a phone book is. But the point is that it is complicated. It does require your knowledge of anatomy and physiology and medical terminology, and as well as coding and the guidelines for coding and sequencing and all of that stuff. It is intense work. And I just want you guys to know that you are at the beginnings of this work. So it will get easier, because you will find your way through the complexities. Now, it may be that you're working for a hospital, but even if you're working for a hospital, there are hospitals that have coders specialize, you know, this coder only does radiology procedures, and this coder only does cardiac surgery procedures. And honestly, I would get bored to death. But the fact is then you also have those opportunities where you get to whatever lands on your desk and gives you the opportunity to code across the board. The fact is that we're preparing you for a successful career wherever you want to go. And it might be in a specialist office where you never get out of 3 pages in the ICD-10 book. Or you might get to work for a walk-in clinic where you get to use the whole book, you know. It's complicated. It takes time. And I know you guys have been through a lot. You've done a lot of learning. You've done a lot of practice. And this is only step 1. And I know that's kind of intense. But it's okay because you are the better of the best. Did I say that right? Anyway, you know what I mean, right? Yeah, you know what I mean. So
Sounded good to me.
And I only speak the truth. As my mother used to say, I only speak the truth so I don't have to remember what I said, because that's the more complicated part. All right. So the fact is that the answer is there. What I will tell you from a test taking tip is, does anybody know if when you're taking this exam, you can go back? Like skip a question and then go back? Are you allowed to do that?
Yes, because it's like a Scantron. It's not on computers, so you can skip whatever you want to
Okay.
skip.
All right. In that case, I will tell you that it is in your best interest that if you have something like this, you try to nail it and you feel your blood pressure going up and you're not any closer to the codes, then I might skip that and save it for the end, because chances are you could probably answer, you know, 5 or maybe even 10 normal questions in the space of time you need for this one. Okay, which will give you more points toward your final grade. Okay, it'll also give you a chance to build up a little more mental confidence when you can go through some questions where you can figure out the answer and feel better about that. Okay, but with the Scantrons, be very, very, very careful. I have known students who have decided to skip question number 9. They go to question number 10, but when they go over here to fill in the little bubble on the Scantron, they fill in the answer as number 9. And then all the rest of the questions are off 1 and all wrong, wrong, very wrong. Okay, so if you're going to do that, be very careful about making sure you skip not only the question, but the line on the Scantron as well. The better suggestion, are you using like a number 2 pencil to fill in the Scantron? Yeah?
Yeah,
Okay.
you do. And the case study part, of course, you got to write it out. It's not
Yeah.
Scantron, but be very careful and look at how it's laid out, because they do questions. The answers are next to each other and below each other. So you got to be sure you're going across the page correctly, because
That's where you're going to use your finger.
Yep.
Right.
I had to erase answers because I did it what I thought was logically, and then I looked at the numbers and I was like, oh my gosh. And I had to erase them all and go back and move my answers to other places. So be careful.
Okay, very good advice. Thank you.
Yeah.
The other thing that I want to suggest is, if you are going to skip over a question and come back to it, use your gut and lightly fill in the answer that you think it is. That way, if you run out of time, at least you have an answer there. And if you don't run out of time and you get to go back to it, it's only light, so you can erase it more easily and change your answer. Okay? Does that make sense? Okay. All right. So you know that that's the way we have to, it is complicated, and that's what we do though. If you want it easy, you could become a math teacher in 3rd grade. Because, you know, once you get beyond 3rd grade, it's like complicated. Okay. All right. We good?
Yes, ma'am.
Good. Thank you. All right. This week, which is week 5, chapter 7 and 8, which you're going to go through your reimbursement questions. Okay. Make sure if you don't understand the new MIPS, the new quality payment program under Medicare, if you're not sure, if the book doesn't explain it well enough, let me know and I can cover it in more detail. I'll give you a website. But the fact is that is relatively new. And it's been in place since 2017. So the chances are they are going to be asking you about that somehow, some way. Okay. All right. You have your textbook, ebook. After you read chapter 7, 7 and 8. And as I said, try and do this without your textbook so you can really check your knowledge. Because remember, when you take the national certification exam, you get to bring your code books, but not your textbook. Do they let you bring a medical dictionary?
No, I mean, I didn't try to take one, but I don't think it
Okay.
says on the form that
I
you
think
can.
AAPC doesn't let you. HIMA toyed a couple of years ago with permitting that. And I remember when I took one of my exams for HIMA, I brought my medical dictionary with me, but I never even opened it up because I felt it was too distracting. And you know, and would take up too much time. So don't even worry about that. But remember that you can, as I showed you with the illustrations in your code books, you can use your code books to help you understand anatomical sites, where they are, what they do, things like that, which can, remember, we're looking for cohesive thinking. You have to understand what the procedure is, what the diagnosis is, what does that mean, what are they doing, because that's the only way you'll be able to figure out, like we just did with the lesions, right? G95.9 was, well, it sent me here. It seemed like a good path, but once I got here, it just didn't make any sense. Okay. And that's using your knowledge that you've learned, all that stuff we've stuffed into your brain over all these courses that you've been taking, right? Okay. And then you're going to do your analysis. Are you finding the analyses helpful?
Very.
Good. That really is, this is the most important part of the entire course. I mean, I seriously mean it, is when you take the time to analyze the answer you got wrong and why it is wrong, what the correct answer is and why it is correct, the differences, that is what's really getting it into your brain and giving you the power to do the analysis. And that is very, very important, because that's going to help you really do it right the next time. Is, I know all these other tests you've taken before, generally speaking, I'm not talking to you guys specifically, but generally speaking, students look, oh, look, I got that wrong. Oh, yeah, that makes more sense. Okay. But there was no analysis, which means there's no penetration. There's no reinforcement in your brain. And that's what you need to construct so that when you're sitting there taking the exam, it will be easier for you to access that knowledge and faster too. Okay. All right. The extra stuff are links to the inpatient and outpatient PPS. And remember that when we say outpatient, in this perspective for this exam, we are talking about hospital outpatient, not outpatient like in the doctor's office, not outpatient as in an ambulatory surgical center. Okay. A lot of it is the same, but some of it is different. So I just want you to be, I know it helps me to visualize the patient coming in, the whole process, putting them on the operating table, what's happening, why is it happening? Also, one thing that's very helpful is as you come across any procedures that you don't necessarily understand, like the laminectomy, you know, that procedure code in PCS is release. It's not laminectomy, which means to remove. It was a release, which is why they talked about the retraction on the side. And so if you come across things like that, you can go to Medline Plus and watch videos, or just Google it and watch videos or simple explanations. I'm not scrubbing you up and putting you in the middle of a bloody operating room. But you need to have a sense of how these procedures are done, so it can help you. It will help you code it more accurately. And that's also why you have to remember to read the entire case notes, whether the operative report or the procedure note or whatever it might be, because there are details in there that will help you figure it out. Okay? All right, questions? Okay, good. Nobody else?
No,
I'm
ma'am.
good.
guys
That was
are
my
the
biggest one.
You guys are the best. I really am gonna miss you guys. When maybe I'll flunk you all so you won't graduate, and then I'll get to have you in my class again. No, I would
Yeah,
never,
please
ever,
don't do that.
ever.
You know I'm kind of particular about trying to get an A.
I do know that. As am I. I want you to know in 2002, my first master's degree, I got 1 A minus, my whole entire program. It still bothers me. And you know why I got that A minus? I will tell you. I got that, and this is a true story. I got that A minus because I kept getting less than perfect grades on my paper. And it took me like 3 weeks to finally get up the nerve to ask the professor why. And then she told me. And then miraculously, I was able to fix it. Okay, no problem. Except it was too late for that little nick in my grade. All right, so a word to the wise is sufficient. Something bothering you, something happening that you don't like, I'm here for you. And Jennifer, yes, I have been going over all those other things, and I will be inputting corrections pretty soon.
Thank you. I'm sorry my email was so long.
Do not apologize. There were a
In the
couple of
future-
things in there I'm embarrassed you even had to ask about, like the O instead of the 0. That's just, and I was talking to Ms. Johnson about it, and I said, I don't know whether I did it or she did it. It doesn't matter. It needs to go away and be fixed.
I do have a question. Well, next time if it should happen again that I have to send you a question, do you need me to paste the whole question in there, or do you just need to know which question it is?
It sure as heck makes it easier for me to paste the whole question. And I'll
The
tell
whole
you,
question. Okay.
right. There are 2 reasons. Number one is your number 2 may not be my number 2.
Oh, I meant if I just put like the top part saying what it was.
Right. The
But
second thing
that's why I wanna
is
make
this
sure.
way I can read it and decide what needs to be done right then and there,
Okay.
as opposed to reading your email, going to the test, finding the thing, reading the whole thing, and then deciding, oh no, Jennifer, you forgot the dot or whatever. Okay.
Cool.
Or, oh,
That's
I'm
awesome.
sorry, you're absolutely right.
Okay.
So this way is much, much, much easier and better, more better for me.
Okay.
And that's
cool.
why they don't let me teach English, but you know. Okay, great question. Yes. Anybody else? Smile for me. All right, you guys, be healthy, be safe. I will see you in the course room, and I'm here for you whenever you need me. Okay?
Okay.
Thank
All right.
you.
Thank you.